Good morning, everyone. This is the April 15th, 2025 meeting of the Behavioral Health Subcommittee of the Incarceration Prevention and Reduction Task Force. I'm co-chair Stephen Gockley with my co-chair Dan Hamill here. We start with the land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. So I'll call the meeting to order. Everyone got a packet which has materials, and we have a number of presentations of interest today. So I'm going to turn it over to Dan to guide us through those.
Thanks, Steven. Hey, before we begin, we still have a lot of new-ish people, and I think it just might be good for us to go through and just do quick intros and then get into the agenda. So I'm just going to call on folks as I see them in my Brady Bunch format here. So Bertie, you're gonna start. There you go.
I'm Bertie Safford, a retired family physician, member of the IPRTF, who is on the subcommittee, and I happen to chair the index committee, which, as most of you know, involves the data portion of the implementation plan.
Thanks, Bertie. Stephen Traff.
I'm Stephen Traff. I'm a supervisor with Department of Homeland Security.
Thanks, Stephen. Good morning. Cedric.
Hi there, I'm Cedric Johnson. I'm a member here as a community member. In my professional life, I do grant writing and consulting with federally qualified health centers.
Welcome. Good morning. Hannah Fisk.
Hi, I'm Hannah, Special Projects Manager with Health and Community Services.
Good morning, Hannah. Brian Estes.
Brian Estes. I'm on the board of NAMI Whatcom, the National Alliance on Mental Illness, and I'm also on NAMI Washington's Public Policy Committee.
Morning, Brian. Hey, Danny Carroll.
Hi, everyone. Danny Carroll, the Bachelor of Applied Science and Social Work Program Director and Faculty at Whatcom.
Excellent. Tori Sandos.
Hey, good morning, everybody. Tori Sandos here from Whatcom Community College, Program Coordinator and Faculty for the Substance Use Disorder Professional Program.
Good morning, Tori. Altini Nelson.
Hi, my name is Lieutenant Kyle Nelson. I'm one of two patrol lieutenants for the Bellingham Police Department.
Morning. Dean White.
I'm Dean White. I'm Special Project Manager part-time for the Whatcom Health and Community Services Department.
Morning, Dean. Jake.
Good morning, Jake Rebush, Administrator for Whatcom County District Court and Probation Department.
Morning, Jake. Mike Hilly.
Yeah, good morning, Mike Hilly, Emergency Medical Services Manager for the county. Thanks.
Thanks, Mike. Heather, I don't know why your name is showing up as Brian Estes. I don't know why that is, but anyway, Heather, go ahead.
Good morning, Heather Flaherty, Executive Director of the Chuckanut Health Foundation, but here as a community advisor on behalf of Dr. Chow Yang Wu today.
All right. Thanks, Heather. And then Steve Harris, Under Sheriff Harris.
I can't figure out how to make my video work, but I'm Steve Harris, Under Sheriff at the Sheriff's Office.
Welcome. Good morning, Steve. And I'm Dan Hamill, Bellingham City Council member, Ward 3 representative, and co-chair with Stephen Gockley. Let's see. I think I recall correctly, the agenda's not up on the screen, but I think our first presentation is from Brian Estes on Medicaid impacts on behavioral health. And so take it away, Brian.
Okay, thanks. Just a minute here. Let's see. All right, can everybody see that?
Yes, we can.
Okay, so I did hold on just a second. Okay, sorry, I put this together this morning a little hurriedly. So this is drawn from sources from the, I believe it's Kaiser Family Foundation, the Washington State HCA, and some from our local NAMI Whatcom. And this, of course, is just based on what's currently in the House budget. You may have recalled that passed, I believe, 216 to 214. The Congress is on a 2-week recess. They'll reconvene, I believe, April 26th or the Monday, anyway, right after that. So generally, this would involve very steep cuts to Medicaid. They might be block granted. Washington State may lose 7 to 9 billion over a 10-year period, puts at risk eligibility, benefits, and access to healthcare, including mental health treatment, and it would disproportionately affect children, seniors, and the disabled. So in Washington State, we have 2.2 million residents enrolled in Medicaid. 45% of our children are on Medicaid, and 60% of our nursing home residents, 1 in 3 adults with disabilities, and over 600,000 statewide receive mental health or substance use services. So Medicaid is the largest health insurer in the state. Billions in provider reimbursements are at risk, and you may have seen, I think, Valley Medical Center and other health systems, are already around the whole state are in a very fragile financial state. And our county health systems will bear the burden of this, and we will definitely see rather extreme health disparities. And I know many of you on the call are more familiar with this than I am. I'm just kind of giving a broad brush here. To spotlight Whatcom County, 70,000 residents are currently on Apple Health, which is Medicaid. As we said before, children, seniors, and the disabled. Funds clinic locally, Unity Care Northwest, CMAR, and supports Peace Health ER and the Whatcom Triage Center. 23,000 of our county residents get their mental health care through Medicaid. This could lead to a number of program closures or them being, severely downsized. And what might happen then? Our crisis systems, police, a lot of our treatment facilities could become overwhelmed. And this is something that's dear to my heart in terms of NAMI Whatcom. I don't know, for those of you that don't know, we provide peer support online and in person to, literally hundreds and hundreds of people, thousands really, if you look at the total meetings they go to a year, and it's all free and it's led by peers. And so, plus, when you look at the impact at the state level, we receive a lot of our funding, NAMI does, from NAMI Washington, and that funding could be significantly at risk. So here's some potential local impacts. Peace Health ER could see a significant rise in uninsured visits. The triage center may lose beds or staff. The county, I think what we're seeing is we're going to shift a public health problem to law and our criminal justice system. And for those of you that are familiar, we have a clubhouse model here that operates in over in the Iron Gate area, and their funding could be jeopardized as well. So The impact could be significant on our BIPOC senior, especially rural Whatcom County and farm workers, reduce crisis care, housing, transportation, and services of behavioral health would be most impacted. These are some voices that NAMI Whatcom has collected from our community. Medicaid supports my son's treatment and keeps him out of jail. Without Medicaid, our crisis center can't operate safely. And finally, this is just about dignity. We need care, not cuts. And for some of you may know, there have been some protests. I have a slide here in a moment that I attended in Olympia, Washington. What can we do? I would say the focus would be on the US Senate, and they certainly don't have support, I don't believe at this point, for the excessive cuts that the House had planned, but that, remains to be seen. Whatever we can do to support our local mental health, especially those that engage in peer support, is really vital right now. And finally, I'll leave you with a slide, and that is yours truly. On April 2nd, they had a Healthcare is a Human Right rally in Olympia, and I was there. And does anybody know who the woman on the right is? That's our insurance commissioner, Patty Kuderer. And with that, unless there's questions, that's my presentation.
Okay, thanks, Brian. Appreciate it. Any questions for Brian here? Brian, you want to stop sharing your screen real quick so I can get
Sure.
to see everybody?
Yeah. And I guess I had a question if nobody else does. Hold on. Sorry.
Looks like we have a question from Tori.
Yeah, no, thank you for that presentation, Brian. Do you have a sense of, because I know in Olympia there's a lot of back and forth about the budget. And do you have a sense of what the state is doing with regard to funding to provide services, or are they just expecting a block grant?
I'm not really sure I have information to answer that question. I know part of this is a big debate over, rebalancing our tax code to fill some of the, lack of revenue. But I don't know specifically in terms of planned cuts, at the state level related to behavioral health at this point.
Okay, thank you.
I mean, I know they are in the budget, but I haven't actually looked to be able to respond factually to your question.
I'd like to point that question to either Hannah and or Dean in terms of any impacts or potential impacts that you see for the work that you all do over at the Whatcom County Health Department.
I think we're still waiting to see what potential cuts are going to happen. I don't know if I can speak to what I know at this point.
Okay.
I don't know if Dean has a different answer.
I don't have any crystal ball insight either.
Yeah. I know it's kind of early and we're trying to figure things out, and crystal ball is probably the best way to put it at this point. But let's, I think just be aware of this, that these are potential impacts and that we're going to have to be dealing with these at some point in the future. Thanks, Brian. Anything else?
I just might add that they're under budget reconciliation processes, so that means there can't be any filibusters. And I just want to mention, if any of you are Medicaid nerds here, there are 3 states in the country, Oklahoma, and I think one of the Dakotas and one other state, that actually have their constitution has been amended to guarantee that Medicaid will, always be funded like at the current level. So when they expanded Medicaid, I believe people probably, on a certain side of the aisle said, listen, we need to preserve this. So what this means is whatever federal cuts occur to that state, the state itself will have to fully fund Medicaid at that level. And in some cases, that's like 30% of the state budget. So it'll be very interesting to see, and these are generally red states. So it'll be very interesting to see what happens with some of these Medicaid cuts. That's it.
All right, thanks, Brian. I think that takes us to our next agenda item. And Jill, I don't have it in front of me, the agenda, but I think we're going into committee, our work group reports. Is that correct?
Yes, that's correct.
Okay. So I kind of want to reverse the order a little bit. And Dean, since your group has met, I wanted to hear from you and Bertie on the data just group and just kind of hear where things are at.
Sure. So we met last week for our first meeting and basically just got to know each other. And let's say Cedric, of course, as well as Bertie were in that meeting. Don't see anybody else, but we basically, just found consensus on what our focus ought to be, which I think is a matter of both being a resource to Village Reach as it completes its work and helping, sort of shepherd resources their way in terms of information they need to do their plan, but also looking beyond their report to recognizing that there's a lot of ambition about what we'd like to do with respect to data and dashboards and so forth, and be a resource for sort of highlighting the challenges that we're going to face in terms of data modernization and systems updates and interoperability issues in order to actually produce actionable information that's consistent with the plan that we're expecting to receive from Village Reach. We're scheduled to meet again Thursday.
That's great. Thanks, Dean. So not everyone on the call is going to understand what a Village Reach is or does. Can you just give like a 30,000-foot view on that?
Yeah. The Health and Community Services Department, using the JAG funds that were obtained to support the Justice Project, solicited a contractor to develop program Justice Project evaluation and performance measurement plan. And Village Reach was the successful contractor, and they are now a few months into the process. They will be completing their work at the end of June, which is when we have to have those JAG funds expended. At this point, the consultant has developed kind of a desk review of best practices in the field. Has done a lot of interviews with stakeholders and has others in the works, and has also attended a number of meetings. And I should mention also that in addition to developing sort of the ideal measures for what people regard as the key measures of success, they're also going to be looking at what data systems do currently exist and what data elements can they provide to calculate the measures that will be recommended. And Bertie and Cedric, I don't know if you want to add to anything I've said about the report or the committee, the work group.
Bertie, go ahead.
Yeah, the only thing I would wonder, Dean, if you think it's worth sharing with this committee and a brief summary, which I could do if you want, of Julia's recommended measures and the questions that need to get asked and thought about and answered.
Sure.
I think for this committee, it would be helpful to see where she is landing. Julia is the head researcher for Village Reach, and in terms of the overall measures for the implementation plan, and to look at the questions that she would like to have answered by essentially the community and all of us. And I think they're very pertinent to behavioral health. So I'd like to take a short moment, if that's okay. So Jill, I sent Jill a couple of slides just to offer a brief summary because I think it's helpful for people that are visual to see, if you don't mind, Jill. So this is one of the summary slides from Julia's presentation to the index committee. And what she has done is taken all the 15 measures and consolidated them into 4 key outcomes. And just briefly, the first is jail bookings, reducing the number of jail bookings. The second is the average length of stay in jail. The third is increasing connections to care once people are released from jail, which she has consolidated all of the individual steps on housing and reentry and those types of things. And the fourth is the overall measure of recidivism. And then those 4 measures would be disaggregated or broken down so that they could be sorted by behavioral health issues and by race and ethnicity issues. So where this particular committee comes in is there's several questions, but there's 4 major ones that I think are really impact this committee. And one of the outcome measures is how many people are released from jail with, quote, connections to care. So the question is, how are we going to define that in a way that is measurable and reflects the meaning of the reentry issues that are embedded in the implementation plan? So that's major question number 1. Major question number 2, because it will be disaggregated by those folks suffering behavioral health issues, is how are we going to define serious mental illness? She looked at one national organization that is trying to look at outcomes from the justice system based on serious mental illness. And there wasn't an easy answer from that organization, but the goal of this measure is to find the people, and this is me freelancing, that have serious enough mental illness that it contributed to their being impacted with the criminal justice system. I mean, I know as a physician, there's a lot of us people in this community that are highly functioning that walk around with diagnoses like depressive disorder or anxiety disorder, et cetera, that are well controlled and functioning normally. And we're not trying to search all those folks out. We're looking for people whose serious mental illness impacts their ability to function and contributes to them being involved with the justice system. And then the third is, I guess I have a typo there, how do we define substance abuse addiction? Because that would also be disaggregated, and that is probably more straightforward, but still needs clarity. And then last and not least, of course, one of the major measures is how do we define recidivism? And we had a discussion on that at Index Committee. And the spectrum is from minor things like you have a parking ticket, you've interacted with the justice system, that's recidivism, all the way to, okay, you're incarcerated again. What if you are then found innocent? So there's some nuances to this that the community has to define about how we define recidivism. The discussion at the index committee was landing on being jailed again, because number one, that's fairly easy to measure. And it is obviously more than a minor interaction with the legal system. It's still very open to community input. And so I wanted to put this out so that we were all aware of these questions and we can weigh in on them. Thank you, Jill.
Okay, we've got a question from Lieutenant Nelson.
Well, less of a question, maybe more of a comment. Couple thoughts on that real quick, if you're open to it, Bertie.
Oh, we're all open to it. Yeah, this is important.
I think one of the things is we often try to put things into singular boxes, and I know from my time on the street, the substance abuse and behavioral health are often commingling. And so I don't know that it's as simple as just teasing those out individually. And then when I look at recidivism, I think just booking in jail is not a great data point.
Uh-huh.
Somebody is interacting with law enforcement on a regular basis and may be arrested with a ticket and not actually booked into jail due to restrictions or other circumstances. And so when we look at recidivism, they may be committing the same crimes over and over again.
Mhm.
They need to be hooked into services, but they may not be getting booked into jail because of the level of crime. And I realize that we're the incarceration reduction, so we're trying to reduce incarceration, so even the ticket is that. But I think when we look at true recidivism, I think that you need to look at a criminal interactions.
Okay. I appreciate these thoughts because I think we will want to funnel all of these various aspects of these definitions to Julia, and ultimately it's not Julia's decision. It will probably land on the IPRTF to make the final recommendations.
I see Dean White and Tori, and I think Brian had his hand up first. Brian, you want to go? Okay, maybe not. Dean, go ahead.
So I think recidivism, that question illustrates one of the challenges we've got in terms of coming up with these measures. I think Julia is focused initially on, if we had all the data that we could get, what's the best way to measure recidivism, or perhaps there are multiple measures of recidivism based on the nuances that Kyle mentioned. What I think others have gone to fairly quickly is, well, this is the measure we should use because that's the data that we have. And so part of the work is to, first of all, identify what are the best measures if we had the data, and then where's the gap between that and what data we have now.
Okay. Thanks, Dean. Tori, do you want to go?
Yeah, I just wanted to weigh in on this a little bit because I think it's really important to, when you're talking about behavioral health and substance use and addiction, and then you're trying to, create a metric for interaction. You have one is a formal diagnosis, and the other is sort of like a community idea about what that is. And so I'm wondering if you're looking for metrics on how to do that, maybe you can sift it into something else, like encounters with somebody who is experiencing a mental health disorder or is substance use involved. Unless you have the luxury of having someone who can do a screening that could make that more defined.
Thanks, Tori.
Just my thoughts.
Brian?
I apologize. I missed a little bit of this conversation because I had to take a real estate call that's time sensitive, but I was just curious in terms of definitions of mental illness. Are we looking to the Diagnostic and Statistical Manual of Mental Disorders for these definitions? Are we looking to SAMHSA? I mean, where are we getting these from? And also, as many of you know, NAMI nationally does not endorse the term behavioral health because it implies a choice, and we would prefer that people talk about, people living with mental health conditions or disorders. So that was my comment, and I guess my question on the definition.
Bertie or Dean, can you answer, or Cedric?
Yeah, I can answer if you want. She is defining it as people with serious mental health disorders, which meets your concern about behavioral health. And the question is an open one. It's up to our community to determine how we are going to define that, because there's a desire to separate in a subset people who are impacted by mental illness and what their incarceration and treatment looks like compared to those who aren't, to see if we're meeting their needs. So it's an open question, and we will certainly be looking for everyone involved's input on that.
Brian, does that satisfy your question?
Could you elaborate on that more a little bit, Bertie? I'm not completely sure I understand the construct here.
I'm not the origin of the construct,
Oh,
but
okay.
maybe you could go back just to that overarching first slide for a moment, just to show Brian her summary slide. I just was passing through the question before this. Yeah, this was one of Julia's summary slides that she presented to the index committee. And I don't want to repeat the whole detail, but just as you can see, she's got outcome measures and then plans to disaggregate the outcome measures by race and ethnicity and by, quote, behavioral health involvement. And and she included both substance abuse and serious mental illness in that box, with the plan to separate those two as you look at them. And so her next question was, we have to be able to define what we mean. And she was using the term serious mental illness because that reflects one of the best practice organizations she looked at that was trying to address how people with, quote, serious mental illness are impacted by the justice system. And I can't remember the name of that group, but it was largely supported by the American Psychiatric Association and others. And they did not have a packaged definition of serious mental illness that we could use. And so she brought the question back to the community.
And who makes that determination that an individual
I
lives
think
with
that's
serious
up
mental
to the
illness?
community, and that's her perspective. Is I'm giving this as a question, and her original question is, who will decide that? Will it be Satpal and the executive? And in the very informal discussions, I think the input from the I'm blocking on the name, JPOC committee and others is probably there will be a recommendation ultimately that comes out of IPRTF.
Well,
But
I guess
maybe
there's two.
Dean can help me out here because
Well,
I'm simply reflecting what I have seen from her presentations to date. And I wanted this behavioral health subcommittee to be very aware of it for the obvious discussion that it stimulates that will be important.
real quick, obviously there's several components to that. There's someone with psychiatric training obviously makes some determinations, but you seem to be talking about more from a policy or kind of data analysis perspective. How are we tracking this in our criminal justice system? So.
Dean, do you have any thoughts on that one?
But just to say, Brian, that I know that Julia very much recognizes the challenges in arriving at an appropriate definition. And so she's aware of the DSM-5 and its role in defining serious mental illness in its various forms. And she's also aware of the challenges of when that determination gets made and when a person is, encountering police or a crisis worker or at the intake at the jail and so forth, that there are other issues that constrain using those definitions. And so I think she's grappling with those nuances. And I would suggest that you know, it might be useful for you to have a conversation with Julia, if it's okay with you. And
I think that, I appreciate that, because I know SAMHSA has done some work in this area related to the
Yes.
issues you're talking about. And what was that Julia's name again, full name?
Julia Garrett, Guerette.
And she's a
I will,
consultant or?
so Brian, I will send you an email copying her, inviting you to make yourself available for an interview with her.
I would appreciate that very much. Thank you.
Sure.
Okay. Hey, Jake, you had your hand up before. Did you still want to?
Sure. Yeah, I just wanted to touch on the recidivism and kind of what I've seen, and just want to make sure, however it's defined, it's very intentional, because you're going to get a very wide range of results depending on if you go bookings, like was previously stated, convictions, arrests, because that would involve dismissals, pending reductions, and then down to police or law enforcement contact. So I know there's just a huge variety in there, and within one individual, you're going to get a big difference there. So I'm just putting that out there.
You're right. Yeah.
Thanks, Jake.
Just real quick, Jake, could
Yeah,
I invite Julia to talk with you, Jake, as well?
What's that?
Could I invite Julia to reach out to you and have a conversation?
Yeah, I'm as part of the index committee as well. So I've had some contact with her. Yeah.
Okay. All right.
But sure.
Okay. All right. Thanks, everybody. Tori, go ahead.
Yeah, just real quick. I second what Jake is talking about in terms of recidivism. It's really challenging to tease out some of those things. My question, though, is that in trying to create a definition of what those are, is there any liability attached to that? If someone comes in and says we're going to attach a definition to a particular patient as having an SMI or a substance use disorder or an addiction, and they don't get addressed in terms of like assessed or treated, is there any kind of liability to the county for that?
Dean, do you know the answer
Well,
to that?
I suspect, given our litigious society, that there is. But I think that first of all, we're really talking about de-identified information from the standpoint of measures. But certainly we can address that question, particularly if it's of a concern to council and the exec.
Okay. All right, I'm just kind of noting the time here. So we do need to kind of keep moving. We've got several other agenda items. I want to make sure that we get to everything today. Any other questions, comments pursuant to data work group? Okay, I don't see any. Hey Brian, I think that maybe if you want to, you're re-entry and diversion, right?
Yes.
You're the convener.
Yes.
Do you want to just give us a 30,000 foot view on that one?
Well, we're meeting next Monday at noon. And I have dug in a little bit to some of the diversion programs, and I've talked to Melora Christensen and Maya a little bit about those. Other than that, we're pretty wide open. And I know there's been some discussion, Stephen has helped with this, that focuses on some reentry issues that we might, be taking a look at initially. But we're gonna have our first meeting Monday, and Deborah Hawley has told us that she's not able to continue on that work group. And so I don't know if anybody else on the call, Hannah or others here, have any comments, but and by the way, a big benefit is we're using my free Zoom account, so our meetings are limited to 40 minutes. I would think that's positive.
Okay, good. Good, yeah. Efficiency is good. Any other folks from that work group have any other comments or questions or? Okay. All right. Thanks, Brian. I've reached out to some employers in Whatcom County, and Carl Weimer, he used to be on Whatcom County Council. He ran a shop. They used to call them closed shops. So it was for folks with disabilities that would assemble parts for a manufacturer, things like that, just to try to get ideas on where for the vocational component of what your reentry looks like, and I'll share that with the group at the next meeting or over email. Okay, any questions for reentry or diversion? Stephen Gockley.
Yeah, question for Brian. I wasn't at the formation meeting, the joint meeting, so I apologize for that. But I'm wondering whether Deborah was a member initially of the work group because she represents a voice of lived experience, or simply her interest, her personal interest. And if the former, I'm wondering what effort we might make to replace that sort of representative kind of perspective.
I don't recall her reason for wanting to join the group, but that's a very valid point. And I think we'll discuss that at our first meeting, because it is very, very important to have people with lived experience on these groups. So thank you for noting that.
Okay.
Okay, any other questions, thoughts?
Does-
Brian, go ahead.
Does anybody else remember when we were identifying people for these work groups? Was that brought up? I don't recall.
I think people are just signing up based on their interest.
Yeah.
One thing that I would add is that the city has a new position that presented last night or yesterday rather. Jason Corneliuson, he's out of the mayor's office, and he might be an asset when it comes to diversion reentry. That's those are two of his focus areas, among others. So I'd add that to the mix. Okay, any other questions, thoughts for reentry diversion? Okay, seeing none, I'll go ahead and bring up Division Street. That's the third work group, and I've thrown out some dates, and I apologize, it's been kind of hectic recently, but we've got a couple of potential dates in early May. We'll probably go with the first date, and I'll confirm that with the group. There's 5 of us on that committee. And Division Street, as you all know, so it's 2030 Division Street is the address. That's the work center. It's where the alternate response team is housed out of, and it's where the mobile medical units from Deep are located, and it's where the Andeacon Center is located. So as you can see, it's turning into a behavioral health campus. The 23-hour behavioral care center will be located there. We did get an email from the chief deputy executive that they're looking for alternatives for that. So apparently funding might be like suspect for that, but I'm hopeful that we can continue that effort. And so the work group would be making recommendations as to what that campus could look like. As you know, the work center will be relocated to La Bounty when the new jail center opens, probably in 3 years, hopefully in that time frame. And so there'll be a big vacant open space within that building. And so the work group would be discussing, what could that look like? Could that be, like a medical / dental NAAA counseling childcare center, basically the kind of replicating the Deep Clinic North. So that's kind of one of the points of discussion. And again, we are a recommending body only, so we're not going to be actually out there building this thing, but we can make these recommendations. So I'll entertain any questions regarding the Division Street work group, if there are any. Okay. All right, seeing none, I think that we can keep moving along here. Jill, I don't have the agenda in front of me. Can you throw that up just real quick?
Tori's next, Dan, with behavioral health education.
Yeah, the next agenda item is behavioral health education workforce with Tori Santos.
Oh, good. Okay, thanks. All right, Tori, floor is yours.
Awesome. I just have some notes for myself. I'm not going to take a whole bunch of time, but I have a couple of kind of exciting things. If you are not aware, Whatcom Community College has 3 programs that provide the educational requirements to become a substance use disorder professional in Washington State. We have an alternative training for licensed behavioral health professionals, which is a cohorted program that takes place over 3 quarters. Instruction for that is asynchronous, all online. It's a total of 15 credits, 5 credits per quarter. We also have a degree program, an associate degree program for the SUDP track. It's for students who do not have a degree. It's 90 credits over 7 quarters, including summer. And it also includes a practicum course. A lot of our students are hired out of those practicum placements. We also have a certificate program for people who already have a degree, 65 credits over 5 quarters. And it is also including a practicum course. The reason why these practicums are so critical has to do with ensuring that students get the proper exposure and training under a licensed SUDP in these agencies, so they're not turned loose independently straight out of school with patients who are in treatment or just getting assessed. So right now, Whatcom has a grant from the Cambria Health Foundation to pay students while they're in practicum, and practicum is 132 hours, and we are paying them at minimum wage. And the reason for that is to sort of support them while they're still in school. This is outside of their loans if they're getting them, outside of their grants. And so we've been working with our partners on how to distribute that. And so this spring quarter is the first time that we are going to see how it rolls out. There are no fees to apply to Whatcom Community College or to the alternative training program. Whatcom is also engaged in providing information to the campus community about Narcan and services for substance use disorders. And we include many of our providers on our advisory board to help keep current in our industry. And when I checked yesterday on Indeed, there were 4 positions posted on Indeed between Whatcom, and I think there were some Skagit Valley positions as well. 14 positions. And so the workforce is still trying to fill positions. The industry right now is kind of going through a lot in terms of changes. The SUDP, drug and alcohol counseling, has kind of been going through a lot of dynamics, probably since 2016 when the Affordable Care Act was implemented in the state of Washington for the work that we do. Behavioral health, like mental health, for a long time was really used to managed care and how all of that works. And the drug and alcohol treatment services have only been doing this since 2016. And so it was a huge lift for the workforce. We lost a lot of people during that process. We also had to embrace electronic health records during that time. And that was a huge challenge as well. And then you throw in the fentanyl epidemic and all the things that go into that. And I think some of these things are contributing to why the workforce is really struggling with this. Prior to 2016, we worked off a lot of block grants. Some of you may remember the old ADOTSA program. And Adotsa had a lot of success with providing treatment, but it went bankrupt because it also attempted to try to support housing. And so I don't have any idea. I don't have any word on whether or not we're going to see some kind of reiteration of that come back. But that was in place for probably close to 20 years, if not longer. When I got started in the field in 1988, it was already going. The other thing about what we're seeing is that we have increased enrollments at Whatcom Community College for this program. I'm also on a consortium of other addiction educators in the state of Washington, and they're also seeing the same kinds of enrollment numbers across the state. This year, we have been offering double sections of our courses since the fall, which sort of surprised me. I will see what happens come let's see, fall and next spring on how many placements we will be looking for people. So that is my mini report.
Thanks, Tori. Any any questions for Tori? Or workforce, or educational? Go ahead, Stephen Gockley.
Tori, that is a positive report. Thank you, and thanks for the work going on over there. I'm not trying to jump too far ahead, but I am trying to think ahead, that we have that open question that Dean and Bertie talked about, is how we define, but how we categorize and where we capture diagnostic information, whether it's formal or observational or self-identified. If we went with a more formal system, would the cohorts that you have flowing through those programs, would that be a place where assessments could be done, supervised, of course, but if we decided that we wanted to have a diagnostic component to those categories in our data, could we make use of the program? And this wouldn't be in place for a couple of years, so your program would be more established, I hope. I'm just noodling about putting pieces together.
Mm-hmm. No, I think that's a terrific question. Our students come out of our program with a trainee license, and so we would have to have a substance use disorder professional be able to supervise their license to be in compliance with the Department of Health. One of the things that we already have in place in the state, it was designed to be utilized in medical clinics and behavioral health clinics, and in just about any setting, is the SBIRT screenings. And so that's a real quick, and I won't say not quick and easy, but it is an evidence-based process that doesn't take a whole lot of time, where someone does the screening, and the person who's trained in SBIRT utilizes a lot of motivational interviewing techniques in order to sort of establish where the risk is with that person. Does this person need to have assessment? Does this person need education? So it can kind of sift those things down, and I can see the possibility using students, as long as they are licensed and they are supervised properly, on being able to perform some of this. I think it'd be a terrific opportunity. I really see the settings where SUDPs practice start to change. There will be, still we'll have our outpatient clinics, our residential clinics, and our detox centers, but you're also going to start to see them more be able to perform these things on mobile crisis outreach teams, in our MAT clinics, and attached to some other things. The state of Washington has relaxed the criteria for how trainees can gather specific competency, and so I think we can start to look at what that might look like. We'll see what the state of Washington does, and hopefully they'll settle down on how they want to impact our field.
Jake, go ahead.
Yeah, I just want to say thank you. I'm so glad that working in probation for the last 20 years. I'm so glad that Whatcom now has a program as well. And for so long it was Skagit. And I'm just wondering, is there at all like a management component at all to the program? It just seems like it would be a great kind of step for those that get involved in our community to remain here and to kind of progress within an agency. It's just a random question. Thank you.
A management component. Well, Jake, I can tell you that I have at least 6 or 7 students that have come through our program. We actually restarted this in 2018, who are currently in management positions locally. So that's sort of been dictated through the agencies. We haven't really looked at, should we introduce something like that? I know that supervisors and good supervisors are sorely needed in order to help support students to progress in their field. When I get some time, I really want to get a mentorship program going, and so it may kind of come through that.
Okay. Other questions for Tori? Okay. Tori, thanks so much for sharing.
Cool, my pleasure.
Okay, it looks like I'm up next here. I'm gonna be brief here. We're still tracking pretty good on time. I just want to make sure we get everyone back to their work and their jobs. So I'm just gonna give a brief update on Deachwall Leak mobile medical units. So I've been in touch with Leon John, who's their outreach coordinator, and Bev Keys, who's their executive director down at the clinic. And there's my latest information is that there's one mobile medical unit up here, and they are doing outreach to try to get people more aware that there are services for Suboxone and methadone. And I wanted to make sure that folks on this call were aware that we definitely need to ramp up the number of patients that are attending and receiving services. And so if you want to send me a message offline just to my city email, which I think you all have, I can get you coordinated with if you're able to do this, or if you have connections with folks. There's outreach materials that need to be distributed, basically. And so we really need to get the word out. The clinic's been very patient at this point, but I feel like we need to really accelerate the process here. So if you're in touch with outreach workers, MCOT, Hot Team, whoever you're working with that has direct access to potential patients, please let me know, and I will get you connected with those resources. And that's really my update. Danny Carroll, go ahead.
I was just going to say, we have practicum students that are in these in a lot of these agencies. So I think giving them to students as well, we can hand them out as well.
Okay. Do you want to just maybe send me an email offline, and we can I'll get that coordinated. I'll get you connected. I'm not the person that's going to give you the outreach materials, but Leon will. He's up here several times a week, so we'll get that moving for you. Thanks for that update. Appreciate it. Any other questions or comments pursuant to the mobile medical units in Deachwall Lake? Okay. All right, let's keep moving. Thanks, thanks, like you're reading my mind here. So we wanted to just provide a brief overdose stats, and it looks like we've got Lieutenant Nelson and Mike Hilly to provide us just some overview real quick. I don't know who wants to go first.
Yeah, I don't mind. Or Kyle, go right ahead, please.
No, I think I've stated this before. I think the EMS is probably the best source of overdose statistics when it comes to, because anything that they're going to, we are going to probably end up going to in the city, but there are probably some that they go to that we don't go to. And so I think to get the full scope, he's probably got the better data than I do. So I'm not going to add anything to that.
Yeah, thanks, Lieutenant Nelson. Appreciate that. And good morning. And I do apologize. The meeting snuck up a little, on me a little bit because I normally provide a packet to upload to Jill, but I'll do that after the meeting for people that want to look at this a little bit closer. But I'll share my screen here. And hope you can see that okay. And this is our 30-day look back. So this slide's a 30-day look of overdoses seen by EMS. This is countywide. And you'll notice here in April, we're still tracking on that 3.5 or 3.6 overdoses per day. And it is interesting to see these spikes that seem to be spaced somewhat evenly on there. And I'm not sure what that's about. It'd be interesting to look at that a little bit more. But nonetheless, this is our 30-day look on that. And oops, sorry about that. Let me move this forward here. Maybe on the wrong slide. Pardon me 1 minute. Yeah, great. So I'll pop that back bigger. So this is a look at just the last 3 years, and it's a monthly. And so, you know, kind of going back to May the 24th, those big days, you know, we've settled down to a little bit, really kind of that average of, you know, 80 to 90 per month. And of course, we're only halfway through April on 41. So I'm not seeing too much of a different trend on that. But it is down just a little bit for EMS. And this is, oh, sorry about that. This is just kind of another way to look at it. 24, you know, 23 versus 24 versus 25. And, you know, only being 4 months in, if you kind of look back over at 22 at that 280, probably be tracking the same for next year, but a little bit difficult to project out. However, yeah, here we are 4 months into 24 or 25 as compared to 24 for overdoses this year. And then this is just a little bit way to look at it as well. The overdoses percentages changes per year. Between 23 and 24, you can see that 39%, or actually that 7% change from year to year on that. And this is just a year-to-year look at the trends going up. And those numbers, once again, are trending a little bit less this year than 24, but we'll see. This is something I do always watch, and it looks like more people are opting to get transported to the hospital. I'm hoping some of the education from the hospital and the buprenorphine program or MAT program out of the hospital is helping with that. And it's also given our providers a little bit more of a tool to encourage somebody to go to the hospital. So I like seeing that number go up. We want to see more. And actually, as related to the future 23-hour center, this would be a place where we could divert people if we could get them to do that if they don't want to go to the hospital. And then these are simply dispatch calls, overdoses per year, and they're going to track really the same as EMS overdoses responses throughout. And then this last one looks at well, first off, Narcan used for calls. So prior to EMS route, this is really good. We want to see that. People are helping save lives out there with Narcan. And this is just kudos to all the Narcan leave at home programs. And then Narcan use with the suspected overdose calls. And so trend a little bit less than 24, 66.7 of those calls last year got Narcan before, as compared to the 53% in 23. So hopefully in 25, we'll see that increase. And that kind of gets represented here too, when we see this increase on a monthly basis for those calls. So, and once again, this is another way to look at it. This is basically Narcan given prior to arrival. That could be a civilian person, it could be a law enforcement officer. And as mentioned before, many times now we're finding that the public's giving more Narcan than EMS is actually delivering out in the field. So that's a good thing. And then here's just some demographics on age and gender. And this doesn't seem to change much over time with, you know, 40% female, 60% male. And this is same tracking through these age ranges. So, and then let me get out of this screen real quick. I'll blast over to, this is our local data. This is off the Whatcom overdose Whatcom County overdose prevention dashboard. This is not my data, but this is the hospital data, and this top line is basically any type of drug overdose. this black line that travels up, and then the blue line below is actual identified overdoses that come into the hospital. And I'd have to take a look at how that compares to the EMS. You know, for those 60% that are going to EMS, that'll represent some of this number, but it's curious how many people may walk in or come in by other means for that. So I looked at this. I haven't seen an update on 2025 deaths yet, but this is what 2024 ended up with. And actually, this is a almost a 3-year look at that. And this is deaths reported to the health department from various, but mostly the medical examiner's office and the hospital report on that. And this is just a quick look at 21 and 23, looking at different finalized deaths. And I'm not sure what the gap is on 24 on that, other than just maybe it just hasn't been updated as of yet. And then here's our overdose deaths per 100,000 population by age. And I'll say this for this slide is really good to look at that per 1,000 by age, because when you look around the state and compare to much smaller counties, that's a better indicator of how you are ranking. So, for example, I believe it was Mason County for a long time had the highest opioid. You know, it's a very small county, small population, but per 100,000 by age and demographics, yeah, they had a very high rate for that small county as compared to other counties. And then this is just some data notes from how this is calculated. So now go to one more report here. We'll see if that'll pop up, and I hope everybody can see this. This comes out of the medical examiner's office in Keene County. Oh, hold on, let me make sure that is everybody seeing that okay? Is that up? Hold on a second.
No.
There it is. There you go. Once again, this comes from the Coverdell grant down for the state, basically. Keene County collates this information for us. And this is, let me move that slide forward. This is a look at multiple counties, mostly the west side, although some east side counties contribute to this data. And this is a total ODs that were part of this study. Now, you'll see the reporting counties down here in just a second for everybody that reports in. But coming out of the Keene County Medical's Officer, this is a report for all of February, 3,073 ODs. And this is demographics, veteran status, the age group, etc. And then the post-autopsy, this is where the information comes in for the contributing factors with all of this. And a lot of times, these overdoses have comorbidities related to them that contributed to their death. Confirmed suspected overdoses by month and county. And you can see here's a listing of the counties. Whatcom County used to report. I'm not sure. I haven't met the medical examiner. We'll try to see if we can get the medical examiner to report again. I will say that for counties that have overdoses less than 10, they tend not to report them in this larger, but I know that's not typically the case for us. And then this is my reference back to the county rate per 100,000 overdoses by county. So this is a way to compare smaller counties with small numbers to the actual depth of the problem as compared to counties that have the bigger numbers. There we go. And then once again, this is just another way to look at contributing factors, substance overdoses. And as we've talked a lot before, this is actually what sort of interests me is that you see a lot of combined substances with these overdoses, and the fentanyl and the methamphetamine tend to be split almost 50-50, although it seems a little bit less this last month with these other, methadone in there, cocaine, benzodiazepines, etc., that contribute to drugs. So once again, many times these drugs are, combined. This looks at polysubstance overdose deaths, and once again, here's that fentanyl, benzo kind of thing, or fentanyl and buprenorphine, fentanyl and methadone, and here's your fentanyl and methamphetamine in that dark reddish there, which is that one. So we're seeing this consistency in meth and fentanyl mixed. Types of paraphernalia used. And this is always interesting to me. And it's, I think the one comment is that, you don't see as much needle use as in maybe years past, and a lot more snorted or smoked or swallowed. There's still a high injection rate, of course, but you're seeing less needles out there. And then here's the indicators, and we do this locally here too. So even the data that you saw earlier, the providers will confirm or have a high suspicion that it was an opioid overdose by paraphernalia found on scene or information from bystanders or et cetera, and those will be noted on the chart. Of course, ultimately, if the patient dies, the toxicology proves out. But sometimes, for patients that don't die and ones that don't go to the hospital, you don't get toxicology on this. So you have to make an educated guess, which has been pretty right on. And here's just history of decedents, their housing status, how they were found. That's not in this one, but I have seen in the past, back to the recidivism, how many times that person has overdosed in a given time period. Not included in this one, but we do have the ability to pull that out of our local data. And yeah, and then here's just a look at the similar we do locally, look at the tracking of Narcan given prior to arrival, once again, civilians, law enforcement, et cetera. And you can see in the trend, Narcan on scene is that the program's working statewide where this represents Narcan given prior to arrival of VMS. And then this is just intel that comes from the field. I know paramedics and law enforcement will take pictures of this to get an idea of how people are using the drugs and what's going on. And once again, you do see needles, but overwhelmingly, you've seen a lot more people smoking and snorting, etc. And then I'll be glad to send the slide deck, and this is the March report for February with all the references and actually some links to articles that have gone on, reference to the drug issue in the state. So that's all I got, and I'll be glad to once again package this up for anybody that's interested and wants to look at the report a little bit closer.
Okay, thanks, Mike. Questions for Mike Hilly? Oh, okay. All right, thanks for the presentation. Appreciate it. I think that takes us to old and new business. Stephen, is that correct? Yeah, okay. Any old and new business that we need to discuss here today? Okay, seeing none, that takes us to public comment. Jill, do we have anyone in the attendee room?
I don't see anyone in our conference room. We do have 2 attendees. If you'd like to speak to the committee, please virtually raise your hand now. It looks like Arlene is one of our members. Sorry, Arlene, I didn't see you there. To promote you. We have another guest by phone. If you'd like to speak, you can press *9 to raise your hand. I don't see any hands raised.
Okay. Brian, go ahead.
I just have a suggestion for a future topic, and that is maybe we receive a briefing from Bellingham PD and the Whatcom County Sheriff about officers that have received the 40-hour crisis de-escalation training. I believe BPD, most of the people have, and Whatcom County is planning to do that. But maybe they could just discuss the training, what its impact, how do we see the results of that, like on the ground? What's the training level of the Whatcom County Sheriff, things of that nature. I think that'd be an interesting discussion point in the future.
Okay. All right, duly noted. Lieutenant Nelson, is that something that you could arrange with one of the DCs or the chief?
I guess I'm a little, are you referring to our patrol tactics instruction 40-hour course or our crisis intervention training, yearly training? Because those are 2 different things. Our patrol tactics is the 40 hours, our crisis intervention is 2 hours a year. So I don't know which one you're looking for presentation on.
Is this course put on by the regional police training entity also, or are these courses all internal?
Well, the crisis intervention is put on by the CJTC, so the overall body of our training. And then the patrol tactics is a course that's created by the CJTC, and then they have kind of trained the trainers. So we have some high level trainers within our own agency who train regionally.
I think all those issues would be interesting. And I mean, I'm just trying to get a sense of the, capabilities in Whatcom County, how that varies maybe between your department and Whatcom County. So.
While I find that interesting, I don't know how that's related to this specific subcommittee, and I just want to be respectful of everyone's time.
Well, this is the behavioral health subcommittee of the criminal justice, interface with the task force. So I just thought that might be an interesting issue.
Yeah, I think it's maybe we can have further discussions offline. Maybe Dan and I can reach out and chat about how that interplays with this specific subcommittee. Because again, I just want to make sure that we stay focused on what this group's trying to accomplish and not. I'm happy to do whatever, but I just want to make sure that we're staying on track for everyone's being respectful of everyone's time.
No, I totally understand that. Thank you for mentioning that.
Lieutenant, why don't you and I just chat offline about that? Try to get some clarity on that question.
Perfect.
Okay. All right. It's 10:17. Anything else for the good of the order today? Okay. Well, group, thanks for taking the time here this morning. You're gonna get it's 10:18 now. You're gonna get 12 minutes of your life back. So definitely appreciate you. And thanks for all the updates from the work groups. I think that we're starting to kind of get momentum, and I just really appreciate the folks that are doing the work, and then the others that will be vetting that work later on. So okay, with that, this meeting is adjourned. Thanks. Have a good rest of your day.